Hi, this is Dr. Sanjaya. In the latest episode of Behind the Curtain, I sit down with Dr. Sean Chan for a thought-provoking chat about the inspiring work his team do in the trauma and intensive care space. Let's jump into our chat. Hi, I'm Dr. Sanjaya. Welcome to another Behind the Curtain podcast. Today we have a very special guest, one of our staff specialists in intensive care and trauma, Dr. Sean Chan. Welcome.
Thanks very much, Sanjay.
And I should add, you do wear other hats, including the State and Territory Medical Director for Donate Life, which we'll definitely talk about. When was it that you decided that intensive care trauma was your field?
Oh my goodness, that was a long time ago. I think the epiphany came while I was working as an emergency registrar. I was working in a small hospital in Newcastle. It was the Tox Hospital, nominated Tox Hospital, which you might imagine brought all kinds of people. They might be having psychiatric emergencies, they might be having toxicological emergencies, and sometimes they were related.
Yeah.
And I don't know, I found myself gravitating towards looking after the sickest patients in resus particularly, and gravitating away from the people spitting at me and trying to bite me. So I found myself making some...
These are patients we're talking.
These are patients,
right.
Yeah. The staff, that was more recreational. I found myself making phone calls to the people who I seem to refer all these really sick patients to, seeking an alternative career pathway.
Wonderful. And so that sort of opened your eyes to the possibility of intensive or critical care, intensive care?
Yeah. And look, it wasn't that I hadn't had exposure to it. So I spent in some of my formative years working in the NHS, and particularly ITU in Aberdeen, in the Royal Infirmary Hospital there, back in the day. And it was fascinating, and they worked so hard, and there were some amazing patients, and amazing staff, inspiring. But at that stage, I thought emergency was where my passions lay, but that got beaten out of me over time.
No, fair enough. And look, within intensive care, like we talk about different subspecialties within a speciality. So cardiology, you can do echoes, or you can do electrophysiological stuff, put in pacemakers. Within intensive care, is there much opportunity to branch out, or?
Oh, look, yes and no. There absolutely are subspecialties, so to speak, within intensive care, but I sort of view intensive care as one of the few remaining generalist specialties in modern medicine. And, I have such respect for acute general medicine as a specialty, but I don't know how you feel about it. It feels to me like it's a dying profession. A lot of the interesting patients are increasingly being looked after by subspecialty teams, and realistically, it's evolved into intensive care. And so we are the last frontier, so to speak, for anyone who's sick, male or female, young or old, whether they're smashed up to within an inch of their life from a major trauma, or they come in as a consequence of a variety of acute and chronic disease states. We're it. And I find that fascinating, particularly personally. It's a great intellectual challenge, and it's non-discriminatory in that respect. And so on the one hand, I can say, yes, there are subspecialties within ICU, for example, ECMO, or
And do you want to tell our audience what ECMO is?
Yeah, sure.
Basically?
ECMO is one of the technologies that we've got that's causing a lot of controversy, and some of our audience might have read this amazing the New Yorker article about ECMO. Like many things, it's a technology that's outstripped our capacity to process things intellectually and ethically. And so you've got people being preserved in this liminal state between life and death with no go-to.
And what at a very basic level?
Oh, of course. Sorry,
ECMO?
It's essentially heart and lung bypass. And so if your heart and or lungs are too diseased or injured to sustain your life, we'll use machines to take over their function. And we for years, for decades, we've had dialysis, and people can conceptualize that.
Yep.
It's probably familiar to many people, both from their personal as well as professional lives. But ECMO, so heart-lung bypass, for us is it was around, but it was one of those technologies that was in search of a disease to make it famous, and that was swine flu.
Back in 2009.
Yeah. So you remember it well. It was one of those things that if you could keep patients alive for long enough and help them survive that initial insult, they actually got better. And so that was the thing. And so there were these machines that we could just keep people alive for a long time. And as we've gotten better at it, increasingly longer and longer times, and then you're stuck in this ethical conundrum where it's a bridge to what? And for some people, would it be a bridge to transplant? And what if they weren't transplant candidates? Because we haven't got enough organs to save everyone. Yeah. Okay, and so then it becomes a bridge to nothing. And now you're stuck in an ethical conundrum. What do you do with this poor patient who you're sustaining with machines who's got no plan B?
That's right. I mean, the technology's there. We're able to keep people alive and stop them from dying from conditions that they would have succumbed to before. And you're right. But does that mean that they're going to end up with the same quality of life they had before the illness? So then that is that conundrum, isn't
Absolutely.
it?
And so not always is the concern. And yes, it's a first world problem. I mean, it's not like we've got that many ECMO machines in outback South Africa, for example, and there are people for whom, we spoke often about people in the subcontinent during COVID. So you didn't die of COVID, you died of being poor. You didn't have access to healthcare, and this is a global problem. And the fact that we're having debates about ethics and technology, it's a first world problem. Most people who we put onto ECMO, I have to admit, would have, even a handful of years ago, died.
Yeah.
Now what do we do? So when swine flu came and went, there was this flurry of spending to prepare us for the next pandemic. And so a lot of units around Australia bought up these machines. And so we had a sudden expansion of this fleet of life support machines, advanced life support machines that we suddenly didn't know what to do with. And so we got bracket creep. And so people who we wouldn't have considered a few years back for this kind of support technology are being placed on this support. And so
we have ECMO in Canberra?
And we have ECMO in Canberra. I've got some exceptional colleagues who have trained in other units and have brought their skills back here. And we've got an expanding ECMO program. And yes, it absolutely does save lives. We mercifully have not had as many of the same concerns about placing people with no bridge. If used as a bridging therapy, we didn't put people on who didn't have a plan B. And so we've been very careful about that. But it's here, and there are places around the world who are running into these ethical problems.
And I think you've also, by bringing up that point, that's a segue into another part of intensive care, which some people may not appreciate. We think of you as running these very complicated machines and patients who, often can't communicate with you. But at the same time, intensive care, there is a very close relationship, if not with the patient who is unconscious, with their family. So I know there are very intense meetings at regularly updating family and friends about someone who's in a very critical condition. So you really need to have good people skills to be in intensive care, don't you?
To be a good intensive care doctor, I think to be a good doctor, I think you need to have a blend of technical, intellectual, as well as interpersonal skills. And absolutely, I do tell my trainees that, what I feel is that at some stage in your career, the medicine almost becomes the easy part. People die from a few common pathways. we are mortal. Everyone dies. Life is a chronic degenerative disease with a 100% mortality. No one escapes it. And so we tend to die via a number of common pathways, particularly intensive care. So the medicine eventually becomes not so much easy, but easier than helping families navigate death and dying. And, you know, another way to frame it that I sometimes talk about is that getting sick and recovering is easy. Getting sick and dying as a consequence is, in some respects, it's clear. It's not easy, but it's very clear. The difficult part's that limbo in between, where you're not getting better, okay, and that's very difficult, and that you have to start to incorporate what people want to imagine life with disability or chronic disease would mean for themselves, and what it means to them as a person, and how that fits in within their family and their social circumstance. And there is no magic formula. That's not easy. You toss in the complexities of families and their relationships, and you never know what you're going to be faced with every time you walk in the door.
Yeah, absolutely. And I think it is really important to have that skill can't be understated in medicine and in intensive care, because I don't envy you some of the discussions you must have about with relatives about really sick patients, particularly when it was completely unexpected.
It's interesting, isn't it? Denial's a powerful drug, and you and I both know that a lot of the diseases that people are coming in with increasingly these days are the end result of chronic disease, and we've gotten so good at kicking the can down the road, so to speak, and sort of preserving people with chronic morbidity and disease, that people forget that there is an endpoint to all of this. And, you know, as a society, I think we've been so divorced from the cycle of life and death, particularly in an urban environment, that, yeah, a lot of people haven't developed the language and social nous to discuss it, frankly. We've anaesthetised ourselves from death, so to speak. And I contrast the conversations I have with farmers. Farmers get it. They see the cycle of life and death. You know, some of us will see, so pets, dogs and cats, they become part of the family, but they teach you something about love and loss that
yes.
many people are only faced with sometimes at the end of a human relative's, not so much a furry relative, but a human relative's end of life. And I think that being anaesthetised to that makes us unprepared for the conversation when it comes time.
I agree, Sean. And in fact, I think people don't contemplate death enough, particularly when they get to a certain age. I got to a certain age not long ago, and I sort of I realised that my chance of dying from various things was exponentially rising. Now, it may not happen for a long time, but you do sit back and think, okay, if it does happen, what things do I want to have achieved in my life that I can achieve shortly? Then from a practical point of view, in terms of estate planning and those sorts of things, is everything ready for my wife, my kids, if something happens, or do I have to do something? So if those things do occur, then you are comfortable that everything will be relatively smooth sailing for your family after you've moved on. So I think that's important. And also, I think it's really important to think about death after a certain age, because it makes that final hospitalisation less traumatic for everybody.
Yeah.
Because I do see some people who are very elderly with a lot of sick chronic illnesses where they're coming in really for the final time, and doesn't seem surprising to me, but the patient is in shock, the family are in shock, and you think, wow, you've never even considered this moment. And it just makes it so much harder for them, and I feel very sorry for them that they have to go through that.
And that's it. And so the difficulty with working with families in that kind of position is that you have to accelerate that learning process, that coming to terms with death, understanding what it means for them, and to do so in an uncontrolled manner through tragedy is probably that's why I think that's the more difficult part of our jobs, and it's in some respects that can be one of the most difficult yet rewarding things that we face. And if you can actually help guide a family through the dying process, I think it's one of the greatest privileges. If you can do that successfully with minimal trauma, that's one of the greatest privileges that we have in our profession.
Just before we leave talking about intensive care, one thing you did raise, which I must admit I never really thought of, but of course it's quite true, is that intensive care is a generalist subspeciality. Because of course we think about, I think I'm in infectious diseases, so every organ can get an infection, whether it's musculoskeletal, cardiac, pulmonary, whatever. So we have to maintain our generalist knowledge. Similarly with oncology as well, because you can get cancers in any part. But I never really thought about intensive care. But of course, intensive care, every organ can get affected, and so many etiologies, whether, as you say, it's trauma, whether it's a poison or a drug or a natural an autoimmune condition, etc. So you need to. So that is another attractive part of intensive care, that you have to maintain that general knowledge of medicine and surgery.
And it's a funny kind of balance, isn't it? Because we do have to simultaneously acknowledge that we are absolutely a collaborative speciality. Because I can't be an expert in every single condition, and so I do rely on infectious diseases specialists like yourself, a surgeon, subspecialty surgeons particularly. A lot of times our patients have multiple issues, and so they might have an infection, but it might be an infection in a joint, for example. That joint was replaced because they had a major trauma, and in fact they've also got multiple other injuries. And so we have to end up being this uncomfortable balance between a highly collaborative specialty, but the buck stops with us, and we have to ultimately using our big brains and heuristics to incorporate all of the recommendations from our colleagues. Ultimately, what's the next best path towards recovery? And so it's that coordination aspect of the profession that I find fascinating.
Sure. Now, the other hat you wear, which is also a very big hat, is that you are State Territory Medical Director for Donate Life. So tell us about, well, first of all, Donate Life, but how you got that interest and got into the position.
So Donate Life, I work for Donate Life ACT, which sits it's a territory-based agency working underneath the Organ and Tissue Authority. Organisationally, the Organ and Tissue Authority national program to coordinate organ donation and transplantation really started in 2009. It's one of those things where it's a highly complex series of everything from public education and awareness to potential organ donor support, identification support, and hopefully affecting organ transplantation for people who need it. For some people, as much as exceptionally important as dialysis is, for example, for some people, survival really depends on transplantation of a functioning organ. And it might be someone who's got AGA nephropathy, so a kidney disease, which disables them so much, because dialysis is not easy. A lot of people are tethered to machines 3 times a week, 3 to 4 hours at a time. It can be uncomfortable, painful, and it's a debilitating condition. It could go to liver failure on the other end of the spectrum. It could be young, it could be old. These people die without a transplant. We haven't got a machine to replace the liver. You can put people onto heart support machines, so left ventricular assist devices, onto ECMO, but these are time limited. People suffer from complications, and so you've got this complex series of programs, therapies, and organisations working together to provide the only possible means of survival for many people around Australia. So it's not easy, even receiving a transplant, let alone surviving for years onwards without. And there's certainly some are more difficult to live with than others. It was interesting. A boss of mine I worked with years ago visited Spain, one of the recognised world leaders in organ transplantation. They've got a very interesting. People always talk about it, an opt-out system. The difference in the Spanish experience, where my boss went along and visited Barcelona and said, "Oh, okay, can you show me your dialysis centres?" He was met with incredulity. What dialysis centres? We don't have people on dialysis. So kidneys are remarkable. They're actually surprisingly robust organs. And, it's taken decades and decades of work to get to this point. But if you give someone a new kidney in 2024, you can basically say goodbye to them. These people are very well managed in the community. You don't see them in the hospital system anymore. By and large, I'm not saying everyone's journey is that smooth. You give someone a set of lungs, and it's like marrying them. They are challenging organs to maintain function in, and so not that it's no. All I'm saying is that yes, it's life saving, it can be life transforming, absolutely, but it's not easy. So my role, getting back to that, is on the donation side, and it's to.
Sorry, I'm just going to interrupt you quickly. So basically, in Barcelona,
Yes.
they don't have a kidney transplant waiting list.
Look, to my knowledge, I haven't been back to Barcelona. From what I hear, certainly that program has been an enormous success.
Wow.
So you contrast it with 14,000 people receiving dialysis in communities and hospitals around Australia, 3 to 4 hours a day, 3 times a week. That's a big difference in the quality adjusted life years. Let's talk about medical ethics and a social justice point of view. We harp on about beneficence, non-maleficence, and autonomy, but very few people talk about social justice. And yes, we're groomed to make sure we're not coercive in the language to say that, it's actually to benefit someone else, benefit Australia as a whole. But the fact is that it does. It transforms lives. So, there are many people for whom, organ donation and transplantation, for whatever reason, some people will find grisly, and they don't like the idea. And some of that's religious encouragement. Some of that's just not liking to talk about death and life and the cycle there. But and so I don't think everyone can be turned around to believe that it's a good thing, but it's unequivocally, it changes lives.
And look, having said that, there are some people who make a conscious decision not to donate their organs, which is fine. That's no problem. I suspect that there are a lot of people out there who'd be more than happy to do it, who haven't registered or aren't aware of how they can register themselves to be an organ donor. So do you want to tell us a bit more about, are there figures around that, about what percentage of people in Australia have registered for organ donation, the ACT, and what we can do about it?
Yeah, that's a fascinating one. So by contrast then, Australia's an opt-in system. You have to opt in to be an organ donor. It is certainly not uniform around Australia. The leaders in being on the Australian Organ Donor Registry is South Australia, with about 70% of their eligible population are actually on the donor registry. A lot of those, admittedly, were grandfathered through their indications on a driver's license from decades past. New South Wales did have it on their licenses at one stage and took it off, and the same was true, I believe, of Queensland.
I think we were too in the ACT.
No, that's an interesting one. We never had it on the driver's license. The reason no one knows about this is because most of Canberra are transients. A lot of people came here from other states. There are, by contrast, the people who've lived and breathed, born in Canberra, is relatively smaller, and so there is no grandfathering from a driver's license, so to speak. And so ACT, in fact, has got one of the lowest rates around Australia for eligible people being on the donor, indicating their wishes on the registry. We're sitting around 26%, I think.
Wow.
The last I looked. And so here's what we know and what we don't. If your family bring up organ donation because you've had a conversation with them that you wanted to be a donor, and you've indicated your wishes on the donor registry, we know that the likelihood of you becoming an organ donor, so the likelihood of your family saying yes to organ donation is around 8 in 10.
Yep.
8 families in 10 will consent if they've brought it up, and that by inference means that you've had a conversation in life and you've indicated your wishes on the registry. That falls to somewhere around 4 in 10 if the staff members have to bring it up and you're not on the registry. So we see a dramatic difference in the consent rate. And all it is a few clicks on an app or a website. Yes, it can be a confronting conversation with your families about your wishes at your end of life. And that's, I think, where people fall into the actually, I'm too young to think about death. I'm too well. It's not something for me. I won't talk to my families about it. But as you said before, sometimes really the benefit of talking about your death is for your families, who are then forced to be in a position to make decisions on your behalf without knowing what your wishes were. And the difference you see it's almost relief. Oh, you're asking me a question I actually know the answer to. Yes, of course he wanted to be a donor. We spoke about it last year. And when I have that conversation, it's not with an agenda. It might be, yes, we absolutely know what he wants. He would not want to be an organ donor. And that's fine. But you see the relief when the family are asked a question they actually know the answer to. Okay. It's one of the few things that it's giving control back to the family. So it's, people have also a misconception about the registry. It's not a legally binding statement. Okay, we can't say that, Sanjay, you've indicated that you wish to be a donor on the registry, and despite your family protestations that we don't want him to be a donor, we can't override them. And so, yes, your family ultimately has veto. And so if you do one and not the other, you don't have that conversation, they may still be in a position to say no against your prior stated wishes. And people have many reasons for that. And I'm not here to second guess that.
We're not here to judge either.
No, I can empathise with what all these people are going through. And so we're not monsters. We're not going to override them. But that's the reality of it, is that we need both.
Sean, we've talked about a whole lot of things, and I guess one thing we haven't touched on is your Canberra story. When did you've talked about being in Aberdeen and Newcastle. When did you come to Canberra?
So we've been visiting Canberra on and off for years. So my wife's sisters live in Canberra. And we finally made the decision to move to Canberra in 2009, and I started working here in 2010. So I've been part of the furniture here in Canberra Hospital since then. Look, we had one child at the time, and we've now settled on 2, and that's it. Canberra's a wonderful place. It's a great place to bring families up. It's it's clean, it's safe, it's progressive, socially progressive. We've got great access to green spaces. It's lovely. So we've got no regrets.
Oh, wonderful. And of course now in terms of coming to work in intensive care in Canberra, I guess you've now got a big shiny building and a big shiny unit.
Yeah. This is such a privilege to walk into a brand spanking new facility that updates us brings us to the state of the art with respect to tertiary level healthcare in Australia. For some people, and I imagine for myself, this is a once in a career opportunity. I love it. It's fantastic.
Sean, it has been a fascinating discussion covering continence and ethical issues and various topics. I hope to have you back later. But before we go, really important, if you want to learn more about organ donation and registering for organ donation, please go to www.donatelife.gov.au, and I believe you can also register through the Medicare app. Thank you once again, Sean.
Thanks very much, Sanjay. Thanks for the opportunity to come have a chat with you.
Anytime. Thank you for listening. I hope you'll join us behind the curtain for our next episode, where we'll delve into the story of another of our fantastic health professionals here at Canberra Health Services. If you're interested in starting an exciting career with us, head to our website to join Team CHS. And that website is www.canberrahealthservices.act.gov.au/careers, CAREERS. I acknowledge the Ngunnawal people as traditional custodians of the ACT, the land I'm recording on, and recognise any other people or families with connection to the lands of the ACT and region.